We are starting our first case. So we are going to start our first case. Mrs. M, 41 years female, having bronchial asthma, was treated by post-wide local excision of left breast lump and axillary dissection, post-chemo, radiation. Now she is in hormone therapy. So I'll first discuss about her first disease from October 2020 to November 2024. So she has got carcinoma of left breast, 9 o'clock, with left axillary lymph node metastasis. Clinical staging was T2N1M0. Histopathology was infiltrating ductal carcinoma grade 2. FNAC from the axillary lymph node was metastatic carcinoma. Immunohistochemistry revealed it is a ER8/8, PR5/8, HER2 negative, KS67 25%. So the patient underwent breast conservation surgery with axillary clearance. And the final post-op histo was infiltrating ductal carcinoma grade 2, PT1N1, 1 out of 7 lymph node was positive. Her tumor size was 2 into 1.5 centimeter. All the margins were free, and there was no lymphovascular invasion or peritoneal invasion. After that, the patient received adjuvant chemotherapy by AC plus taxane regimen up to 3rd May 2021. And she also got external radiotherapy with boost up to 27 June 2021. She was on tamoxifen and follow-up since August 21. And she developed lymphedema of left upper limb and post-chemo amenorrhea till now. Her last PET CT was done in 24th April 2022, and the findings was normal. So this is her mammogram of November 2024. There was post-operative surgical hips with clusters of microcalcifications at upper inner quadrant of left breast, and the comment was fat necrosis. Post-radiation changes in left breast, no focal lesion in right breast, normal right axillary nodes, and normal left axilla. So on follow-up, in January 2025, she developed pseudo-orange whole breast with edema of the nipple-areolar complex of her right breast. There is a contralateral breast, non-tender lumpiness in right breast in upper outer quadrant, and multiple mobile right axillary lymph node. Her left breast and axilla revealed no abnormality. So what next? How shall we proceed? Dr. Ismail Jafri, microphone please.
So I realize genetic testing is not done much here in Bangladesh, but I think 41-year-old patients in the United States most likely would have actually tested to determine whether or not she was a carrier. And given the histories, of a new cancer in the opposite breast, it's such a short interval, you have to wonder if this patient is potentially, for example, it's an ER positive breast cancer, so potentially could be a BRC.
It's a luminal A.
Pardon?
Luminal A. So ER positive,
Yeah,
negative.
so it could be a BRCA2 mutation carrier. So that would be a concern. So I think in the first instance, given her age, I would have suggested a genetic testing. But if it's not done, it's not done. That's the point. But this, and then in terms of making the new diagnosis, you say there's Port Orange. I would do a full thickness skin biopsy to establish whether or not there is involved with the tumor lymphatics. If there is, this is an inflammatory breast cancer. You can also then I would say that you should get your systemic therapy, and then modified radical mastectomy. We don't do some little biopsies for inflammatory. You should get post-mastectomy radiotherapy if this is inflammatory.
Okay. So any more comment from any other panelists regarding the workup of this patient?
I will go for 4 months of the right atrial lymph node and 17 CIH.
Okay, so regarding imaging, any comment?
Yes, I think this particular patient had breast cancer 2 years ago on the left side. 4 years ago, left side, and one single lymph node was positive out of 7 lymph nodes.
Yes.
and she had chemotherapy and she was on extreme stage, some sort of hormone therapy as well. Now she has developed another cancer. We don't know the histology of this side at all. It's just a quarter-1 change you have seen. So first of all, I'll do some staging. Of course, mammogram, ultrasound, everything should be done. As SMILE suggested, yes, if you think it's an inflammatory cancer, definitely you need to do some sort of full thickness biopsy of the skin and dermal tissues. And staging is important. Whether this is coming from the previous cancer or this is coming a new cancer on the right side, both are possible. So staging with a bone scan and also CT chest, abdomen, pelvis. Some people actually do CT PET scan as well, but I think nothing is actually superior to anything. So you can do a staging first, find out what kind of cancer is that, with the grading, and also lymph node. You have mentioned about lymph node.
Mm-hmm.
If lymph node is enlarged, then we do some biopsy as well. These are the imaging technicality.
Okay. So, anything else from the panel?
Actually, supplement with first of all, I go for what I explained, that then I will go for metastatic imaging.
Metastatic what?
Before
Okay.
that, I to clear that what has happened in that area.
Okay. Dr. Dusan, anything? No. Okay.
So I think in terms of clinical radiation oncology, we would be influenced by what the response was to systemic therapy, so that if all the inflammatory changes had resolved, the patient would probably go into mastectomy and chest wall radiation. But if the inflammatory changes have not resolved, then we might proceed directly to radical radiotherapy on the basis that if the inflammatory changes have not resolved, and then the patient then goes to surgery, we get recurrence of clinical.
Okay, thank you. So I'm proceeding up to the imaging. So this is the ultrasound of the breast in January 25. So it showed malignant lesion at 9 OC in right breast with microcalcification. The size is 14.3 into 12.7 millimeter. New lesion since 17 April 24. It's virus 4A. Right axillary metastatic lymph node, 2 nodes. The larger dimensions are 1.63 into 1.2 centimeter. But isoechoic scar at 10 o'clock in left breast. It is also a new lesion since 7 April 24 and normal left axilla. So, and the mammogram showed malignant lesion 30 into 18 millimeter at upper outer quadrant of right breast, right axillary metastatic lymphadenopathy, post-operative surgical clips with clusters of microcalcification at upper inner quadrant of left breast, that is the ipsilateral breast, and normal left axilla, virus 4A. So, any comment now? Any change?
We'll do biopsy. Have you done the biopsy? Biopsy from the right side and left side as well as
Both.
lymph node
So
biopsy.
initially the plan was biopsy from the right side, now left side as well.
But you're suspicious of the left side as well.
Yes.
So left and right biopsy and right axillary biopsy as well. We'll see what they show.
Okay. Any comment about MRI breast? Do you want to do MRI breast for this patient?
Let me know the biopsy result first. Think about MRI breast. And the plan will depend on what kind of biopsy. If it is an inflammatory cancer, so how this MRI is going to help you.
After seeing the mammography and sonography,
Actually, I don't know. It was not inflammatory. There was a beauty orange change. So,
Okay.
there
So can you
beauty
tell
orange
me the
change.
biopsy result? Yes, MRI is one of the options of modalities to see.
But
you
no
have
features of inflammation, no features.
But you have to understand why do you need to do MRI.
Mhm.
If you are trying to do breast conserving surgery and if you want to see whether it's a unifocal lesion or multifocal lesion,
Mhm.
and you have got doubts about the diagnosis, and if there's a dense breast, that is the time we need to organize some sort of MRI.
The patient is 41-year-old, and the patient has some scars in the ultrasound. So, isoechoic scar. So, do you want to clarify this? Isoechoic scar in the previously treated breast.
Sorry, I'm answering, but of course my colleagues will answer. But I think left breast, you said there's some microcalcification around the deep area. Am I correct? That was picked up by your mammogram.
Yeah.
And mammogram hasn't added anything else than what you saw 4 years ago, 3 years ago on the left side. On the right side, you've got multiple areas of cancer.
Yeah.
In that sense, if it is dense breast, yes, MRI will help. But it all depends on what is our plan with the breast.
Okay. So we have done the biopsy, and the histopathologist said right axillary lymph node, metastatic ductal carcinoma, right breast core biopsy, IDC grade 2, and left breast core biopsy is also IDC grade 2. We did the immunohistochemistry of the right breast, ER positive, 7/8, PR negative, HER2 equivocal, P53 scatterly positive, Ki67 30%, and dish was not amplified. So, is it luminal B or luminal A? Because now ER positive, PR negative, HER2 negative.
Right at this.
Any comment from pathologist?
So I think because this is the new tumor, right?
New tumor, right?
Do you have the spore for the left side?
Yes, I have.
So is it different?
So it is also ER positive, PR negative, HER2 equivocal, but the dish report is
From here
LG.
it looks
Similar, yes. But it is different from the earlier tumor because the previous one was different. So it was ER positive.
So at this point, both tumors, both sides are ER positive
Yes.
and HER2 negative, right?
Yes.
HER2 negative.
But the left one is still equivocal because the dish report is pending.
Oh, it's pending.
Yeah, but for right side is negative dish.
But you know, it's difficult to predict what will happen in the left breast, but most likely it will be negative also. So I would. I mean, if this is the biopsy came to me first, I would have done the same thing. Compare the morphology with the old left tumor from the left biopsy that was like 4 years ago, and then you have a new tumor in the left breast again, right? In the scar. Was that malignant also?
Yeah. This was the left breast lesion
So
was the scar.
currently you have two tumors.
Yes.
Two new tumors. One on the
One in the
left scar.
ipsilateral breast, one in the contralateral breast.
Okay, so I would compare the biomarker status of right and left, and but I can't comment much more than that. The Ki67 also looks very similar.
Yes.
One is 30, another 35%. And Ki67 is usually, it's not very useful in for management of the patient. And I also am not sure why BBCC was done here. I'm not very sure what its role in this World Cup. So that's my opinion.
Okay, thank you. So we did staging PET CT scan, and surprisingly, it said that no hypermetabolic lesion in left breast or right breast. Multiple metastatic node in right axilla, subpectoral region, low and hypermetabolic nodes in the prevascular, non-avid pre and paratracheal nodes, left-sided pleural effusion, and some hypermetabolic activity right ala of the sacrum, though the SUV max is low. So now, what is your working diagnosis? Is it a new primary? Is it recurrence after 4 years?
Difficult to say, but I think one thing is very clear from here, that we depend on PET scan too much in this country. PET is not a very good test for staging. Quite a lot of people I've seen, instead of standard staging, like CT chest, abdomen, pelvis, and bone scan, we quite often are seeing patients going for CT PET scan to work out the metastatic status. Just remember, PET cannot pick up if lesion is less than a centimeter or so. Sometimes it might not be even picked up, even if you know the diagnosis of breast cancer. In her case, both breasts have got cancer, but it's not been picked up. So stay as a staging the way we normally do, as much as possible. Second thing is, it's most likely, I mean, it's a recurrent cancer. When do you say recurrent cancer? Recurrent cancer is the same breast, same size, similar kind of pathology, but she had chemotherapy, so there might be some field change due to the chemotherapy effect. That's why it's ER positive and PR negative now. It was positive before, correct? And she was in the prime treatment as well. So, as I said, Professor Jatray said, we'll do genetic tests to make sure that there is no gene alteration, and the treatment will depend on if there is any metastasis anywhere else or not.
No, I mean, I think the PET scan, there's nothing definitive that's saying metastatic disease. The pleural effusion is very low. I wouldn't go further. I would say the PET scan is negative for purposes of treatment. She has bilateral breast cancer.
Yeah.
Whether it's a recurrent to both breasts or two primaries, they're the same in terms of the way they look by IHC. I agree, P53 really doesn't play a role here. I think the PR is lost because it happened on tamoxifen. Exactly. So it could be either. Practically speaking, it probably isn't going to make a big difference. The only thing is, was the skin biopsy, was there dermal lymphatic involvement in the breast that was described as polyp orange?
So do you do skin biopsy for all the purely orange cases?
Well, if I think if someone is raising possibility of inflammatory breast cancer, and my surgeon shares the concern, then I'm going to look for that. Yeah.
Okay. So clinically, it was not inflamed, so I think.
So that was. So you didn't agree? Okay. Let's go.
Okay. So, what is the plan of treatment now?
Well, I mean, so again, I think at this point, again, genetics. But you mentioned the code orange, so it wasn't the.
There was purely orange, but there was no inflammatory change, other inflammatory change or redness. So do you do biopsy, skin biopsy for all the purely orange cases?
I would do a full thing of skin biopsy to see if there's involvement in dermal lymphatic. If there is, then it's inflammatory breast cancer.
Okay.
So, and then of course the management changes. You give the adjuvant therapy, and then you do a that's technically what I'm saying. Cell lymph biopsy will involve. I mean, you wouldn't do something with any of these clinically no positive. But I'm just saying that would change things.
So now about treatment. How should we proceed?
We differ slightly in the UK. Well, of course, in America, most of pure orange, and if there's a doubt about inflammatory cancer or not, that is the time we actually do some punch biopsy of the skin or full thickness biopsy. But in the UK, inflammatory cancer is a clinical diagnosis. If you think that this is inflammatory, red, absolute orange, and red everywhere, you can tell it's inflammatory cancer. We don't do biopsy. But of course, if it is doubt, you have to do it.
Yeah, I think when Professor Jatray says skin biopsy, it's actually not, it's not a different biopsy. It's actually you do a punch biopsy that has the skin. If it's ulcerated, you see the skin ulceration, and then underlying the tumor infiltration with dermal lymphatic involvement. So it's actually just a regular biopsy, but a punch biopsy. That should be quite informative.
Okay. So now.
Also that the punch biopsy, the morphology and the morphology of the previous biopsy, if they match and whatever be the hormonal status, maybe slight differences there between the two. But I think that can be taken as metastasis. Morphology is important to what I want to say. That morphologically similar to tumors, then in that case, it's better to take it as metastasis.
So from the left breast metastasis to right breast, right? Okay, it might be. Okay, so how should we proceed for treatment? What is the plan, treatment plan?
Switch over chemotherapy, second line or MRCPS.
From medical oncologist?
Well, I mean, I think you'd have to, the surgery would only make sense if you could do surgery on both sides. And if one side is showing nodal disease, I'm not sure going directly to surgery would make sense. You also are missing HER2 on the other side.
It's a huge lymph node in the right atrium, huge.
But the left side you said was HER2 2+ with your D-dish head.
In the left side. Left
You have
side
that?
2+. Right side dish negative.
But what about on the left?
Left dish not waiting. We are waiting for that.
Yeah, so probably, in the United States, it probably would err, and this is, you could go 50-50. It'd probably err on this being a new process because it's the ARC-DID switch. You could send an oncotype on both, which is the recurrence score. Unfortunately, I don't think it's available in Bangladesh.
Very expensive.
It is.
Very expensive.
It is.
We send the samples to US. Very expensive.
So just FYI, the reason it's so expensive, it's not a CLIA certified test. CLIA just means this is a technique of doing this test. Take it to your lab and you can do it, and once we verify it, you can have it. Oncotype doesn't do that. Oncotype is a proprietary test. It can only be done in their lab. So that presents a problem everywhere. So we would probably we would talk about, does an oncotype make sense? She did this on tamoxifen. So the question is it endocrine sensitive or is it endocrine resistant at this point because it was on tamoxifen? She's 41 years old. Is she menstruating?
No, chemo-induced amenorrhea. Chemotherapy induced in amenorrhea.
4 years.
Yes.
Okay, so she's at this point I would consider her postmenopausal.
Yeah.
One could try aromatase inhibition. One could, you'd have to make the argument the opposite way and say this is metastatic disease from a primary. And if you said that, then the CDK4/6 inhibitors come into play. So it depends on how we as a group would think about this. Either it's bilateral new disease or it's metastatic.
That's why I asked you that, whether you consider it bilateral new primary or it's metastatic.
I think you lose nothing.
Because treatment plans,
Sure.
areas.
You lose nothing by starting on an AI for 3 months and seeing what happens. So, granted, surgery doesn't usually come into play for 6 months on an AI, if you even could contemplate it. But you lose nothing by just seeing what happens to the disease with AI therapy. I think you can go either way. I mean, if you're going to call it metastatic, I would have been more convinced to start a CDK4/6 inhibitor if she had disease outside the breast.
Okay, please.
Can I clarify the status of the paratracheal nodes which were enlarged? They're not regarded as metastatic, or is this equivocal?
No. Paratracheal SUV was not that high. It mentioned
You have the lymph node on the right side as well. On the left, so she has another lymph node on the left side as well this time.
but there's
On the right side. That's what I'm saying. So you do X-ray clearance and mastectomy on the right side. Convince patient that we probably better that we don't have to think about it, and then wait to see what's happening. She can have a high chance of metastatic cancer later on. So we can put her on, as you said, from AI, different one. And instead of tamoxifen, we can try exemestane, we can try, or aromatase inhibitor, and see.
Yeah, I mean, the best case scenario would be this is new disease. That's the best case scenario because it's curable. So, if you want to approach it that way, then the surgery does make sense. My personal bias, even though I would recommend a 3-month course of an AI, it doesn't produce a high PCR rate. And if you're going to get, quote, neoadjuvant therapy, the goal should be PCR. So I'm not a big fan of endocrine therapy as neoadjuvant treatment in ER-positive disease. So if we want to be optimistic, we treat this as new breast disease. We see no evidence of metastatic disease convincingly, and you do surgery.
Okay. Yeah.
Can I clarify whether any further imaging was done on the right side of the ala of the sacrum? A suspicious lesion there on PET scan. Would you not do either some selective cuts to the right ala or MR of that area? It's going to affect whether you're going to offer some form of local regional treatment. I don't think we'd leave that uninvestigated.
Okay, so the SUV max is not that high as well for the ala of the second, it's 2.68. So still, you suggest a bone scan?
Well, I mean, I think the point is, and this is where radiology can be very helpful. Right? Well, I mean, we need to ask, and I do this all the time in the United States, is like, how worried are you? Because you're using this cannot rule out. But by radiologists tell us, how worried are you about this? And if you're worried, then yeah, I would do an MRI.
That's part of the staging.
Because there is a lesion in the ala of the sacrum.
PET scan is done, so what is also
Bone scanning is, I think, in this case.
Okay, if there is no comment further, I can conclude my case here. Thank you very much. Sure, sure.
So the pleural effusion was negative, you say?
I said, please consider it negative. I have none. We haven't done it yet. So just make it a case scenario. Yes. If it is pleural effusion is positive, then the treatment is very easy. So I'm not going to do that. So we haven't done it yet, but we consider that if there is no pleural effusion, if there is pleural effusion, there is no nothing to discuss here.
Was ecadherin done on the tumor? Sorry? Ecadherin was used?
No, not done. If you have any suggestion, you can tell, because there are students here.
Because there is, pleural effusion and some bony lesion, I would do an ecadherin to rule out an ocular carcinoma.
Okay.
See, there was a small leak on the paratracheal region.
Yes, but it is reactive.
How was it excluded?
Yeah, the radiologist said it to be reactive. It was not that significant.
So in that case, I think they have to, take some more time to see what happens if the paratracheal leak goes.
Okay.
Just follow up.
During the treatment procedure, right? Okay, thank you very much.